Welcome everybody to the All Ireland ITP patient virtual meeting. We'd like to welcome Dr. Gerard Crotty, one of our medical advisors, and Gerard will be attending our annual patient conference in Manchester this coming May. So if you've got any other questions for Gerard that you would like to ask him, you can actually ask him and meet him in person in May. We've also got some board members here, Rhonda Anderson, our senior patient mentor, trustee Anthony Hurd, and my deputy Diane White. It's great to see our patient conference is taking place at the Bridgewater Hall in Manchester on the 10th of May. So if you haven't got your tickets yet, please come along. As I said before, Gerard will be there looking after one of our sessions there as well. So that would be really good. I've got a quick question, Gerard, that came in on email today. A lady who is 39 weeks pregnant, diagnosed with ITP, her count is 53. There is a problem getting IVIG, or she feels she needs IVIG. I know generally the safe, as long as it's over 50, the count is generally declared to be safe for childbirth.
Yeah.
No complications expected, but she's asking, is it possible to get IVIG privately? Now, I know in the UK, as we found out today, IVIG is basically now hitting the NHS hospitals, but as far as privately, is it available in Ireland privately, or?
ITP is it's quite readily available in Ireland. We don't have the same restrictions as there have been in the UK. I know there's a lot of NHS, there's even an IVIG.nhs.uk kind of site about the actual procedure for getting approval for IVIG in the UK. But in general, in Irish hospitals, public or private, there is no, including maternity hospitals for this person, presumably would be that there isn't any great restriction. There would be, if the pharmacy, and it would generally be held by pharmacy, being a licensed medical product, if a clinician requests it and the pharmacy staff feel it may not be appropriate, there would be passed by hematology in a hematological indication, and so this is where we might have the dilemma. We might be asked by the obstetrician whether it was appropriate to give IVIG or not.
Okay.
It's you can always, when there's a guideline value, you can always pick there are counts that are borderline. So as you say, over 50 is said to be the safe limit for childbirth, and this is slightly above that, so it would be acceptable to go and fine to go ahead. The other question though would be about an epidural, because the risk of an epidural hematoma, bleed next to the spinal cord, is really quite low, and particularly with a platelet count over 50. But it is something we worry about because it could have very severe consequences. So the general advice, and the advice of, for instance, the Association of Anaesthetists of Great Britain and Ireland.
Is it over 70, is it then, isn't it?
Well, yes, 75 or 80.
Yeah.
In the absence of other coagulation abnormalities, if the patient had another coagulation problem, then that on its own mightn't be adequate. But in the absence of other coagulation abnormalities, kind of 75, so below that, so if you are in labor with a platelet count of 54, that's fine. There's no need for urgent platelet transfusion, and IVIG probably in labor probably might be too late to have much of a measurable effect, but the epidural wouldn't be done in all likelihood. So if the patient has a preference for an epidural or is thought likely to be needed, then and a week out is of course, anyone in the later stages of pregnancy, we don't know the timing of labor. It could come on unexpectedly, but so you're in a gray area there. You could give intravenous immunoglobulin, and probably in our hands, if the patient was not in labor and it was the preference to bring up the platelet count, we would probably allow it in that situation. If it was above 80, we'd say no. No need to.
It's that borderline. Rhonda, you got your hand up?
Yes. Related to this, but not necessarily specific to pregnancy, if you have an IVIG infusion, how long would you expect it if you had a very low platelet count, say under 10, and you wanted to bring it up for an operation, which I understand you usually like to have about 80 as the minimum?
Well, 50 for some types of surgery, 80 for a few specified types, like neurological or eye surgery, that sort of thing. Certain.
So how long does it take for the from day one, for the platelet count to go up significantly to have a procedure?
Yeah, it takes. The peak would be about a week. We say our 7 to 10 days would be the peak. So if it's elective and you're trying to time it, we would try to give it 7 days before the procedure. However, it does go up, in the first couple of days. So if time is tighter than that, you might still see a significant improvement within 2 or 3 days. And it is quicker. It's generally thought to be quicker than steroids. When we're treating primary ITP, steroids and IVIG are the two first-line treatments. We don't, certainly in Ireland, we don't use anti-D as a primary treatment. So of the two, they both have around the same, 70+% response rate. But one advantage of the IVIG is it can be a bit quicker.
It was just that when I had IVIG, it didn't put my platelets up significantly at all.
No, well, the response rate, 70%, in the 70s%. So there are 20-30% of people where it may not work, and steroids may work. Combination may work, or we sometimes people are refractory to first-line treatment, and we have to move on to second-line treatments. And of course, it does vary. I don't know. When we put someone on steroids, which is usually our first-line treatment, if the patient's not bleeding and there's no urgency, we often get a response within 3 or 4 days, and the patient can go home. We don't have to wait till the platelet count normal if someone's admitted because of severe ITP, but the platelet count is like, if all else is well, the platelet count 20 and rising, we'll send the patient home and see them as day patient after that. But I tell patients that the length of time to response is quite variable. There's kind of a long tail. The longest in terms of the extreme outliers that take a long time to respond. My very worst case was a patient who was 10 weeks in hospital with a platelet count below 5 before we got it up. That was only one patient ever had that duration of admission. And in fact, later on, it doesn't necessarily predict that the patient's going to do badly long run. That patient, later on, they really didn't develop chronic ITP and as well without any treatment. So,
well, thank you.
Good stuff. Thanks so much for that, Gerard, and thanks, Rhonda. Thank you. Right, Owen and Elaine, any questions? All right, Marhad, you got your hand up? You're on mute. God, I wish I had £1 in the last 5 years every time we said that. Okay, go ahead.
If how much should your platelets be before they can start on Alentropec? What level should the platelets be? Being or no other issues?
Alentropec,
yeah. Well, as you say, Alentropec typically is not used as first-line treatment, although there are trials of combining these drugs with steroids. and otherwise in first-line treatment. But we treat first-line with either steroids or immunoglobulin. And then, I mean, if that works perfectly and the patient has a satisfactory platelet count, we might not need to start a second-line treatment at all. But in most adults, ITP is persistent and then chronic. In other words, it persists for longer than 6 months or a year. And we don't continue, certainly we don't continue steroids in high dose for a long time. I mean, that's one of the changes in the guidelines. We reduce the steroids. And so it all depends then, if the platelet count falls, whether we would start a second-line agent, and eltrombopag is one of those. It depends on what is a satisfactory platelet count for that patient. So for a patient who doesn't have any particular additional risks for bleeding, a platelet count over 20, 25, 30 would be often quite acceptable, and we wouldn't necessarily start a second-line agent, because all these treatments have potential side effects. So if someone can live a normal life with a platelet count in the 30s, that is fine. On the other hand, if they're a rugby player, that won't be suitable, or if they're having still significant symptoms despite a platelet count in the 20s, so there's a gray area there. So it will be different for different patients. So we have to, and because it's a gray area, there's a role for patient preference. So if the platelet counts in that gray area between 20 and 50, I mean, we wouldn't be starting any new treatment. If the platelet count was stable off treatment and above 50, we wouldn't be starting a new treatment. But if it's below that and in that gray area, then there's a role for shared decision-making with the patient. And if it's below 20, then, there's clearly a need for additional treatment. So they're the kind of values we're thinking about.
Okay. Thank you.
Okay, to answer your question, yeah?
Yeah, thank you.
Thank you.
Okay. At the last meeting we had, that there was a long discussion about ITP and the possible effects on your cardiovascular system. Are you more at risk? Now, the feeling was possibly, but maybe not. What's your view, Gerard?
Well, I mean, I suppose this mainly applies to the fact that ITP, paradoxically, although it's a bleeding disorder, if your platelets are low enough, and it's also a prothrombotic disorder, particularly for venous thrombosis. There is at least a statistical increase in venous thrombosis. That is deep vein thrombosis or pulmonary embolism in patients with ITP. Now, and this is, in some cases, despite the platelet count being below normal, which you might think that a platelet count below normal would protect against venous thrombosis, but this is not always completely true. Some patients do have, are at an increased risk of venous thrombosis. In terms of arterial thrombosis, so that's heart attack or stroke, I don't think there's any great evidence of an increase in risk. Now, the other thing would be the effect of treatments on the risk. So, in particular, patients who have their spleen taken out could have a higher risk of thrombosis. If you've just had your spleen taken out very recently, obviously that's major surgery, and your platelet count can go above normal, and there can be an acute risk of thrombosis. But even in the long run, people whose spleen have been removed may be at slightly increased risk of venous thrombosis. In terms of other cardiovascular risks, I think that the other thing is, again, some of the treatments, particularly the thrombopoietin receptor agonists, so the likes of L-Trombopag, Avatrombopag, and Romiplastim, they stimulate the bone marrow to make more platelets. So they do, in some cases, produce too much of a response. The platelet count goes above normal. And in some patients who have kind of fairly unstable ITP, the platelet can vary quite rapidly between being well below normal and being above normal. And particularly if you get an extreme high platelet count, it's thought that may be a risk for a clot. So we try to avoid that. I say in most patients that's relatively easy. We adjust the dose of these drugs as outpatients, and we just make small adjustments. And the platelet count settles down in a acceptable range. But there are some patients who have quite variable platelet counts, it goes up and down. And I'm trying to think. I mean, some other, whether there are any cardiovascular risks with other treatments. There's a variety of immunosuppressive drugs, but in general, the side effects there are not primarily cardiovascular. Steroids, of course, can put up your blood pressure and can put up your blood sugar. And so indirectly, that could, in theory, at least increase your cardiovascular risk. And that's one of the reasons we don't give high-dose steroids for long periods. Now, we tend to wean the steroids off and start another different drug if required.
Okay, thanks for that, Gerard. Elaine, have you got any questions?
Just wondering, in your discussion at the recent meeting, was there any other particular cardiovascular?
No, that was it. Actually, you actually covered all the key bits. Yeah. And you had more or less the same answers as Adrian, which is superb. So well done. Elaine, you got any questions? Elaine, no? You're on mute. Bottom left.
Yeah, no, I'm actually, I actually missed the meeting last week, but when I watched it on the YouTube video, I was quite impressed with it.
Okay.
Because I'm actually on Arthrombopag, and it answered a lot of my questions. Like, I've got some symptoms like my hair's falling out, and I'm feeling more tired than normal, and my bones are hurting. But like it answered all my questions. So I just I'm actually quite happy to be on the drug. So
okay, so you just mentioned is your hair actually falling out, or
has my hair? It comes out in little bits, Bits of brushing my hair more, and it's a lot more thinner.
And that's with L-Trombopag.
Arthrom, the Platelet. Yeah, I started on that one. But
Avatrombopag.
But my bones are hurting a lot, and that probably explains why.
Is that
hurting?
In your experience, Gerard, is that a common symptom that's reported?
The aching bones, I did hear recently about someone who had that, but the hair loss, I don't think I've come across it myself with the patient. I'm not sure how common it is.
Because it was raised last week, wasn't it, Diane?
Yeah, I had shocking hair loss with L-Trombopag about 2 or 3 years ago. I didn't with Romiplastim, and I'm on Avatrombopag now. I'm not having a problem, but it's a bit off the record this, and it's just personal. But I found, Eileen, that having juiced celery every day consistently brings your hair back.
Oh, really? Okay.
Yeah, and interestingly, apparently, cancer patients do that too. Have you heard that, Gerard?
What does that too?
Celery juice is amazing for bringing your hair back, and cancer patients do it a lot.
Right, I haven't heard that. I mean, we have a lot of cancer patients under my treatment, and I haven't.
Never heard that.
I haven't heard that.
There's a specific phytonutrient in it by all accounts. Anyway, listen, I got on the celery juice and my hair grew back.
Well, I'm sure celery, we should all be using
diet. That's good, yeah. So
we should all be eating more.
Everybody, no.
We should all be eating more vegetables. I'm sure celery juice.
I don't like celery.
It's healthy one way or the other. I mean, if I have celery, it's usually in a Bloody Mary or a Virgin.
Yeah, and me, yeah.
Depending on whether I'm on call or not.
Yeah. In the chat, Anthony's just said he had a similar thing with rituximab in 2010 and 2013, where it's either rituximab or the England football team, he said. I suspect it's probably the latter, yeah. The way they was playing.
Yeah, of course. I mean, obviously stress or whatever, anger, that football team, maybe it could be a factor. I mean, the other thing, I mean, hair loss can also be autoimmune, and people with ITP can have other autoimmune phenomena as well. So, in a few cases, perhaps that might be an association.
Yeah. This is a very interesting discussion because Diane and I are actually currently working on a survey to try and get the feedback from the patients on the symptoms that they're experiencing with TPOs. This is very apt actually for us, right? So
I mean, hair loss is definitely mentioned on the TPOs pharma list.
It is.
Of the most common side effects, that 1 in 10. Correct. But like Mervyn said, it'll be interesting to see how it comes out amongst a survey.
And are you doing any control group in your survey of patients who are not on that class of drug?
We haven't really thought that detail of it yet. So,
Because, some symptoms, because I know, just again, totally aside from ITP, but there was a recent study of patients on statins and, whether they have muscle aches and pains. And a lot of them did, but there was a control group who weren't on statin, and they also had aches and pains, the same amount of aches and pains. So,
that's a good point, actually.
It kind of, some of these symptoms are common in the population, independently of whether you're on
whether you're on that particular drug or not.
Exactly.
We already have listed the question. Are you on any other medications? So.
Other than these, so it would be interesting to see.
Narrow it down,
Yeah. Okay. Sally, have you got any questions? I know you joined us late, but you got any questions? You're on mute, so no. Owen? I'd rather have a glass of what you're drinking, Owen, than my coffee, so yeah. Great stuff. Okay.
No, it's not. It's just celery juice.
Celery juice.
Do you buy that already prepared, Diane?
No, I've got a juicer. But no, I'll tell you what else I do as well. It's like my secret here. That helps the hair immensely is a shot of really good olive oil every morning.
What, drink the oil?
Yeah. I literally have a shot glass of it,
Yeah, that's supposed to be good for lots of things. It's supposed to be very anti-inflammatory, isn't it?
Yeah.
But the stuff that they peddle for that is so expensive. But if you just buy the ordinary stuff in the supermarket, if you want to do it, I mean, I'm not promoting this or anything, but people are saying it's good. You just get the ordinary extra virgin olive oil and you take a teaspoon of it, and if it's got a little peppery taste when you swallow it, then that's got the polyphenols in it, and they're the things that you want for the anti-inflammatory apparently, and that is what is helpful if you want to go down that route. But you must always look all these things up, of course, beforehand and find out from your doctor if it's suitable for you to take and all of that sort of thing. So, it comes with the disclaimer. But if you want to look that up, I think it is worth looking up to evaluate for yourself if you wish to.
Okay, thank you, Rhonda.
I think as well, all these things, we have to find out personally what works for us. It doesn't work for everybody by a long shot.
Okay, there's a question in the chat. A lady's told one of the people in the meeting here they want to go to Peru. It's a lovely part of the world, to walk in the mountains, 15,000 feet above sea level. Platelet count is around 45. Could that be a problem?
Yeah, well, I think it depends a bit on the patient's history. I mean, any other medical issues and their fitness and so on, and what the nature of the trail is and so on. And also on their ITP history. Are they recently diagnosed, or is this chronic ITP where it's well known how it behaves? I mean, if the patient has the platelet count of 45 shouldn't be a problem. Most patients with ITP that have a platelet count of 45 are either, I don't know if the patient's on treatment or not, but if they are, it would not need to change. It would be a stable situation. I suppose the biggest issue with the ITP here would be if the patient is prone to frequent relapses with very low platelet counts, and what do they respond to? Are they familiar with what works for those relapses, and is it something they can they have access to medical treatment when they're there? I suppose in theory you could envisage someone who knows that a short course of steroids will work, taking some. But I mean, how will they know if their platelet count is low? I mean, I don't know whether this person is planning to stop by somewhere and get a blood count when they're there. So I suppose it all depends. I mean, if the patient is, there's no, travel to any part of the world, Peru or anywhere else, is not free of risk. And I think we all have to take judicious decisions about the wisdom of going somewhere. So I think if the patient has very stable platelet count and knows their treatment well and knows how to manage it, that there's probably no significant issue. If they're prone to frequent severe drops in their platelet count that require admission to hospital, if that's what's happened over the last year or two, then that might be a different issue. Because the questions then would be, but do they have medical insurance that will cover the trip and travel insurance? And what if they're unwell, whether they're up a mountain or not? If they become unwell, can they get medical treatment there and so on? So it's difficult to give a generic answer. It really depends on the history of the person's ITP and also the nature of what they're doing. If it's short, short daily walks, that's fine. If they're going to be in a remote area, distant from civilization for a lengthy period, that's a totally different matter if one is prone to become unwell.
Because I suppose it also all depends on how that person's ITP actually presents, doesn't it? Because some people can have a count of 45 and bleed. Other people have a count of 10 and have no symptoms at all. So if every person's different. So
yeah, absolutely. And whether they have are they on other medications, obviously platelet count of 45. Most patients don't bleed with a platelet count of 45. But if someone's on an anticoagulant for another reason, while having a platelet count of 45, 50, that's a totally different situation. That's kind of just borderline too low. And probably they would want to have a consultation with their doctor before traveling anywhere to see should they have an increase in their ITP treatment. So it does very much depending on the person's history and other risk factors for bleeding.
Another one on a similar theme, as we're sort of, talking about someone traveling to some far-flung place, because of summer will be approaching sooner than we think. It's going to be spring soon, and people. A question that come up last week and one of the meetings before was about flying with low platelets, and the usual things about making sure your health insurance is up to date, etc. But have you got any recommendations for someone who's known to have low platelets but flying?
Yeah, in general, it's not a major problem. Again, it depends, as you say, on the patient's bleeding phenotype, as we would say, whether they actually express symptoms of bleeding. I mean, if someone is just very recently diagnosed and it, has a platelet count below 10 and they have a trip next week, I would be advising them to cancel it, because they just don't know what's going to happen, how they're going to respond, are they going to have further bleeding symptoms and so on. But again, if someone has a low platelet count in that 20 to 50 range and they're asymptomatic with that, there's no reason why they shouldn't fly. And again, I suppose, if it's very low and the person is prone to having bleeding episodes, there might be some concern. What if you develop a nosebleed mid-flight or whatever? But, I think people have to be sensible and, make a judicious decision. If they're, if they have a lot of symptoms, then it might be better to wait until the situation has improved. But if someone's asymptomatic with a stable low platelet count, flying is not contraindicated. And again, just make sure that you have the appropriate medical insurance or cover, EHIC card to cover, receive, in just like you have at home. If you're unwell, how to get medical treatment, and can you access it?
Yeah, basically be sensible. Yeah. Okay, right. Any other question, Anthony? You was talking then.
Yeah, I mean, certainly that I would echo exactly what we've just said, that when I was diagnosed back in 2006, it took about a year really for me to sort of get on top of my platelet count. And once that had happened, we just went about our business in a normal way, really. So travel and flying was just normal, really. I mean, and as my specialist said, I asked him, can I travel with my ITP? And he said, well, you can't travel without it, which is fair enough. In the sense, it's always going to be with us. We've still got to live her life, So I think if you get too hung up about these things, you'll never do anything. But on the other hand, common sense is the way to go. Yeah. There is a terrific article, leaflet on the website about travel and flying, and I think we've been through all this quite a few times.
Yeah, we do.
And people still get hung up about it. So have a look at the leaflet on the website. It's very good, and it should reassure most of us, I think. Okay. Hopefully.
Great stuff. Great stuff. Any other questions? Anyone?
There's one there from Sally in the chat.
Right, missed that one. Go on.
So Sally's on mycophenolate mofetil, or MMF as it's often called.
I got it. Yeah.
And has hair loss. And the consultant said they can't fund me, I think it is, for the TPO, or is it thrombopoietin receptor agonists, the likes of eltrombopag, avatrombopag, and romiplastim, for at least a year post-diagnosis. Again, I think some of the restrictions in prescribing that people the prescribers are held to the license firmly are not quite as firm in the Republic of Ireland. So I don't know what jurisdiction this person is in, but
Sally, could you put in the chat where you're based, so we can see which health service it is? Certainly,
if I feel that, so I guess you're not in the Republic of Ireland, because practicing in the Republic of Ireland, if I feel eltrombopag or avatrombopag or romiplastim is indicated for a patient, and I can prescribe it. There may be guidelines there, but they're guidelines. They're not enforced, and guidelines cover, the 90% of patients. There will always be some patients who are an exception, So so I, in terms of whether there's wiggle room in the UK to have it prescribed out, it'd be worth asking. Now, again, if the platelets are 40 and stable, again, if there's no bleeding, that might be fine. The question is whether, I don't know if the MMF is continued or if you've stopped it. But sometimes the immunosuppressive therapy, you can reduce it and the effect might carry on, So one can, and again, there are different doses of mycophenolate mofetil. You can reduce the dose. So there are a number of options there. I think the thing there is to discuss those with the consultant. There are other treatments that are not TPRAs. I mean, again, I'm not quite sure what the restrictions on prescribing of rituximab or other agents is in the UK. And again, I know even the different home nations in the UK may have, for certain drugs, the rules may be slightly different in England, Scotland, Northern Ireland, and so on. So,
well, there are some issues as well within the UK at various NHS trusts, regarding budgetary issues, etc.
Right.
There has been some fun and games going on. Sally, can I just ask, could you put in the chat which hospital you're actually attending? And whilst you're doing that, Anthony, you got your hand up?
Yeah, just to sort of reassure Sally, if you like. I've been on MMF since 2016, February 2016, and I've had normal platelet counts since then, give or take like the odd cold here and there where I've dropped and come back good again. And I'm on only 250 milligrams twice a day, so 500 milligrams, which I think is about the least you could possibly have. So I'm very happy with that. And as the doctor was saying there, I would suggest, if it isn't broken, don't fix it. As long as you're not having any symptoms, any bleeding symptoms particularly, your platelet count's 40. Okay, we'd like it higher, but if you're not having any symptoms, then don't try to change it. I would suggest, but luckily I've always been above, well over 100, between 100 and 200 really is where I sit. At the minute it's 170, so I'm more than happy.
Yeah. The key mantra now is, the last few years is, don't chase the number. Treat the person, isn't it? So treat the
symptoms, not the platelet count.
That's it,
I mean, the platelet count's only one aspect of it, and it's obviously a vital aspect of it. But there are other things doctors will take into account. Each case on its merits, I guess that's all you can say, isn't it? But reassuringly, MMF has worked wonders for me. So hope that reassures Sally in some way.
Can I just add, Mervyn?
Although
we know there are some restrictions around some of the NHS trusts in respect to some of the medications, what we do know from this last year's patient survey, is that patients can request for an IFR, an individual funding request, and our survey shows that I think something like 97% don't get refused. So it's important to bear that in mind if you are a patient and you think that you're hitting a brick wall, because you can advocate a bit further yourself.
The key here, though, is does the patient actually need it? Are they having any detrimental symptoms? If there's no symptoms and it's over 30, it's generally good. So right. Sally said she's at St George's, St Helier Hospital, part of St George's Trust.
Right.
Now, that's in London. Is that the one we're doing, Diane, later in the year?
St George's, yeah.
Yeah, it is, isn't it? Okay.
Yeah.
Okay. I think I've got your email address, Sally. I may well get in contact. So, because we're doing a patient meeting there later in the year. What's the date of that, Diane? Can you remember?
I'm off the top of my head now.
It's March, isn't it? It's
Adrian's doing it. Yeah.
I
think it's St Helier. Sally is talking about. I don't know if you've.
Yeah, it is. Yeah, but
it's all part of the
St George's Trust. Yeah.
Okay.
Yeah. So, because we're helping them with a patient ITP patient meeting in March there, and Diane was going to go. No, not Diane.
No, Adrian.
Going, isn't he?
Adrian
Newland's doing it for us. Yeah, great stuff. Yeah. So that's good. So you might well get an invite to that, Sally. So go along. So I'll let you know when it is, and maybe you can ask the question. So, okay, that's good. She said yes. Thank you. So I'm pleased with that. Right. Any other questions? Anyone? Well, I think we've put it to a close then now. It's not many people, but we've had some good questions and some good debate. So just a reminder that, as we've already said, we have got our patient convention in Manchester on 10th of May. There's some fantastic speakers going to be there, including our very own Dr. Gerard Crotty from the Midland Hospital in Ireland. He will be there as well. And he will be signing autographs if anyone wants an autograph. So, yeah. But thank you very much. We will set dates for these meetings again later in the year, but we've got a few in-person events coming up, as we've already mentioned, one at St George's, one in Manchester, and there will be others, Nottingham, Liverpool, and a few others elsewhere as well during the course of the year. But as always, thank you for everyone for taking part, and look forward to seeing you all again. Thank you. Take care. Bye-bye.
Hey, pleasure.